Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining us. My guest today is Dr. Peter McCunniff, orthopedic spine surgeon at Advanced Spine and Pain. He's a Valley-based leader in minimally invasive and motion-preserving spine surgery and has performed multiple first-in-the-region procedures. All right, welcome to the show, Dr. McCunniff.
Thank you for having me. You nailed the last name. It takes a long time, so I'll give you a credit on that.
All right, thank you. So, breaking ground here in Arizona. Do you like to be on the cutting edge, no pun intended, on some of these things?
I do. I think it helps. One of the things that I've, kind of realized over my life is that I really don't ever want to be complacent in what I do. So I think
right.
I'm always trying to find, I think as we, get older in our careers and things like that, we find that we're almost trying to buy our time back. So I care a lot about efficiency. And I think that's one of the things that I've, realized going from a hospital-based employment to now private practice, and things that, I think have hopefully helped me and can help other surgeons in general get more of their time back, because there's so many inefficiencies, I think, in the medical system that we'll have to, work on as we go forward.
For sure. Yeah, you mentioned some good stuff there. A lot of the physicians I know, surgeons as well, spend their time, which is not best spent, on the phone talking to insurance companies and trying to get things justified and covered. It sounds particularly frustrating in this day and age. Can you speak to that a little bit? Has that changed any time?
I think a lot of things, and I can only speak to my specialty because I think there's a lot of, I know there's, from where I did my training in Cleveland, I think one of the, breast or reconstructive breast surgeons who does a lot of oncology has become, very famous recently for her own issues with insurance companies. I guess from my standpoint, what I've realized is that, at least in spine, I think there's a lot of upfront work that you can do, but it is not easy. I have these things called templates when I do my notes. So they're very, I say 2 words into a microphone and it spits out this, 6-paragraph thing that hopefully appeases most insurance companies. And I think that doing that is a huge benefit for me personally. But these are all things that you have to do outside, those are non-billable hours. You do those in your own time. You're getting away from your own, family and friends and personal activities. So they don't make it easy on you by any means. And
right.
I think there's been maybe one positive change in my recent insurance experiences, at least in spine, which is I had someone who was admittedly a spine surgeon, said, hey, I'm here to review XYZ. Why are you doing this? And they've been somewhat open to research in the area. So I think that's one thing that has come up. Now, the bigger companies like Cigna, Aetna, United Health, they're probably not, and I will just say they're not, super open to changing their guidelines and things like that, even despite, new research. So
it's harder to get the newer procedures approved?
Yeah, procedures or something that you're going to use in a procedure. So one of the things that I would, for example, so there was a thing that was very popular in the 90s and early 2000s, which was bone morphogenic protein, which was a lab-grown thing that you would use to build bone and help with fusion rates. There was also this possible scare with increased cancer risks that's now been disproven. But one of the things is it is a very strong, potent agent to use in surgeries, and it can cause bone where you don't want it. So I usually do not use that. And there's some of the more recent kind of innovations in bone grafting that I tend to use, and there's good level 1 evidence to support it. It's tough when you might run into a insurance agency who doesn't recognize that, and they would rather have you use something much stronger like bone morphogenic protein. So that's where I think some of the
Huh.
I would hope that as we go forward, they can be more open-minded to some of these things that, because I'm really just trying to, you know, be more, I mean, this is for the patient. It's
Sure,
usually
sure,
less
and
costly, and, you don't want bone where it's not supposed to be, or it can be a bad thing.
sure, and it really is case dependent. You really don't need some bean counter dictating medicine
Yeah,
practice.
absolutely. And what I found is, that's what, just a lot of the people who kind of make those decisions don't have a whole lot of experience in
Right,
patient care, and especially like I claim to know a lot about a very small area, but you don't want me reading EKGs, you don't want me, doing other
right.
things outside my realm, and so I think that when they get too spread thin, that they might maybe not be the best folks to make
Sure.
those
Oh, for
decisions.
sure,
Yeah.
for sure. You also mentioned earlier on you're it's required in the field, but also it sounds like you like being at the cutting edge or the forefront and always learning and growing and improving your skills. And
Absolutely. Yeah.
it's kind of the nature of medicine, really, right?
Yeah.
I mean, you have
Yeah.
your to stay credentialed and certified,
Yeah.
board
Yeah.
certified, etc.
I like to think I go hopefully above and beyond. I think for me, it's more of a, when you get to become your own surgeon, you've gone through training for years and years and years. I think
Hmm.
some people, it's easy just to do the same stuff that you were taught, like in
Right.
fellowship or residency. And I think that becomes more like punching a clock. And I think it goes to job satisfaction. I think there's a lot of like,
Sure.
I do a lot of unique things that are either from the way that I do surgery to the way my practice is set up, those things that are really hopefully continuous improvements, because that's where 1% better every day is what I joke around and say. But
Hmm.
honestly, I'm always trying to find ways to either give myself more time to do what I love, hang out with my family, or things like that, rather than just do the same thing over and over. And it's not a bad thing that they did something a certain way 10 years ago. It's just that I think we need to be open to doing things differently. And yeah, it's a little bit of an upfront cost, but it pays dividends in the long run because it will
For
save you
sure.
time, and hopefully it's a way, that is unique to surgery, which is I want to get people in and out of the hospital sooner. Less
Sure.
downtime, things like that, that hopefully, you know, uh, go against kind of the grain, which I think is classical spine surgery. I tell patients all the time, I know I've got to undo 20 years of bad publicity in spine surgery when I walk into a room. And that's okay. I never try and, I think some people might scare people into having surgery or whatever. The good news about what I do is purely elective. I offer surgery to people. I tell them what their problem is. The good news is that mostly, if you walked in my clinic, it's not the trauma bay, it's not the ER. You can walk out, and I'm just here to hopefully provide some insight
Right.
into what your options are.
Right, right. And I mean, your program is set up where they have all sorts of other things, and the insurance companies too make sure they try other options and stuff. You're not usually
Absolutely, yeah.
the first option. But also, you mentioned the advances. Things have changed a lot in the past
Mhm.
couple of decades, and continue to. The U.S. isn't exactly the quickest adopting, medically speaking.
Yeah,
But yeah, you got to keep pushing those forward. That's all.
yeah.
Kudos for doing that.
Well, thank you. Yeah, yeah. Hopefully, the beginning of good things. I think the more that we can prove, one, safety first and foremost, but a lot of stuff that are very basic that are outpatient procedures now, patients would stay in the hospital for days to weeks.
Right.
We've realized, one, you probably don't need to do that, and two, it's incredibly expensive to do that.
And better outcomes the quicker you can get
Yeah,
them moving
exactly.
again and
Mhm.
moving around. So that's awesome. All right, so rather than get into some of the misconceptions that people might have on
Yeah.
some of this stuff, let's talk a little bit more about the model. And you just switched over to advanced spine and pain. Can you talk a
Mhm.
little bit about that and why you like that model?
Yeah, absolutely. So I think that one of the things that is unique about spine is that I am all for somebody doing something short of surgery before, so hopefully the model is in mind, right provider, right time, right treatment. So really there's 15 to 20% of people who might have a herniated disc or a spine problem that are ever going to need me to do anything. And so I talk in kind of my past experience where I came out of fellowship and joined Banner, which is a big healthcare system, and they're very similar to any of the other healthcare systems in the area. But a lot of what would happen is I would get referrals from the primary care doctors, and the notes would say, patient refused physical therapy, referral to ortho spine. I'm like, whoa, whoa, whoa. We've skipped like 60 steps in here. Say this person does have a surgical problem. You've done nothing to try to alleviate it before you get them to come to me. And so I that was one of the big frustrations is I would be seeing, you know, I think conversion ratio we talk about in surgery is the number of patients that go to surgery versus the number of patients seen. So it was about 1 in 20. So I'd have to see 20 patients before I found someone who's actually a surgical candidate.
Right.
Now,
so somebody that was a good return on your experience and time.
Or they've done the conservative stuff. It's pretty, that it wasn't, and that doesn't even really take into account people who either refuse surgery or people that were, too unhealthy to undergo surgery. So there's a lot of other things that are even working at a disadvantage, for you as a surgeon. So I think that I realized that fairly early in my practice, and one of the people I credit with that, it's not somebody we know in the Southwest or Midwest, but Alexander Vaccaro, who's a very prominent spine surgeon and orthopedic surgeon in general. I listened to his talk about the Rothman model and the way that they line things up. And really, what's unique about spine is I give the example of general orthopedics. So if you have a knee problem, arthritis, sports injury, whatever, you're going to go to the office. You're going to see the surgeon's PA. Usually, they might try an injection, and then hey, you come back 3 weeks later, you don't do well. Okay, you might be a surgical candidate at that time. That is very different in spine because we as spine surgeons don't do the conservative measures like so many other specialties. So that's actually a whole different subspecialty, which is pain management or interventional pain management, different names like that. But really, there's great success with trying things like targeted epidural steroid injections, selective nerve root blocks, all these things that can help people get better and also help me, identify what potential areas might be their most bothersome. And then once someone has failed that, come to me. Now, when you're in the healthcare system, you have to outsource that to one of the private groups because really no, hospital systems or groups have the pain management physicians employed. And I think this goes back to things that I know just a very little bit about, but a lot of what they do is outpatient. And so, when there was a boom in ambulatory surgery centers and things like that, they were the ones who were there doing that. And the hospital systems had really no reason to, invest in them. But in spine, it's crucial because it's one of the steps that you should go through, and most insurance companies are going to make you go through before you ever, get approval to go to surgery. So I learned that it's very important that you have that close relationship with them. And when I was at Banner, I would block off the first hour of my clinic. I gave all of them my cell phone. I say, hey, first hour, you guys tell me you need somebody in the next day. That's what I'm going to do. And it was a lot of extra work on my behalf, just to kind of get quality patients who had done everything short of surgery in the door. And, I kind of started searching for pain management physicians who shared my interest in trying to be under the same umbrella, which is exactly what we have at ASAP or Advanced Spine and Pain, where we have absolutely everything from in the care spectrum, which starts out physical therapy, chiropractics, medication management, then pain management injections. Then I'm there. If somebody, fails all those other things. But that way, my conversion ratio of people that I see, it's about 1 in 3 to 1 in 5, which is exponentially better than the 1 in 20. And that helps me because, I like to think I put a lot of time in learning all these techniques and things that I think can make people better. But if it takes me, an entire clinic day to get one surgery or 2 surgeries versus I'm seeing people, that I can help all the time, that's a big difference. And it makes, my job satisfaction, and all those things better from a surgical standpoint because we've at least tried everything short of surgery, and that way I can have an honest discussion with them about what things are available to hopefully help them out and change their lives.
For sure, for sure. So look, it sounds like you had to make a lateral move to get a more functional model, a more efficient model.
Yeah.
Okay.
It's called well, I guess somebody who knows more than I do told me, one of the things that happens is, as you alluded to, insurance companies. I was a little naive when I first got into this. I was like, you know what I'm going to do? I do a good job of recording all my patient reported outcomes. I'm going to be able to go to insurance companies and say, hey, look at these outcomes. Look at how well my patients do, and let's negotiate things. They don't care about me as one or two providers, or they only care about the hospital systems where they can get a lot of physicians in one kind of grouping. So I'm still much happier being out of the hospital employed position, but it is the cost of autonomy. There's other ways that I guess
Right.
you kind of make up the difference in whatever you want to think from a salary standpoint or production standpoint. But really, it just I'm so much happier when I have control of things. I think that's one thing that you will hear from a lot of physicians in whatever area is that we've somehow gotten ourselves to a point where we gave up those positions in the C-suite office or administrative roles where people who are actually in the trenches dealing with this stuff could have feedback and dictate
Right. Made the
policies.
decisions. Yeah.
It's not that way anymore, and I don't know that it'll ever be that way again. But private practice is one of the ways that it is shrinking because of all these different factors, insurance negotiations being a big part of it.
Right.
But I think that most private practice physicians are happier than they would be in a hospital employed position.
Okay. Yeah. I've seen a lot of physicians when they first start off, right? And people, they go through so much school and sacrifice so much stuff. And then, like yourself, they do a fellowship and they go,
Hmm.
the first few years, right? They're talking about the cases and the detail and the work and they're into it or whatever. And then ultimately they start realizing, okay, I need to be productive and be more efficient. And
Hmm. Yeah,
that's what they
exactly.
start,
Yeah.
yeah, they start talking about a little bit more of the those challenges anyway,
Hmm.
and start thinking about how to grow the practice. They get a little bit see a little bit more of the maybe the C-suite, but more of the administrative
Yeah.
roles, and they sit in those positions. But again, it's a balance of what's the best use of their time and their
Yeah.
experience at that point.
Hmm.
That big challenges to be sure, and
Yeah.
private practice allows you to a lot more freedoms. You can do a lot of that, so that's great.
Yeah.
Do you have any other goals? So do you have sort of future goals for in this position? How long you want to be there? Do you want to be in administrative positions at some point?
I mean, I don't think it. So I think why a lot of this, I think really the administrative stuff, you really almost need to be in academics, honestly, because that's where a lot of, the people who were, they had a day blocked off for that, that I tell, people that the golden age of medicine is gone. Like, when I was in residency, I'd hear about famous surgeons from where I did my residency. It's like, oh yeah, they did 3 cases a day, took the whole team to lunch. They're making 30 grand a case. There's a big misconception out there about how much your physicians are actually the cost burden of what your bills are, and we are not much. I promise you. And
For sure.
I think that a lot of people sometimes, and maybe I may be wrong in this, have negative connotations about their physicians when truthfully, these are very altruistic people who
Yes.
really want to trust me. None of these things work. When you go through residency, that would be a flunk your business school application immediately because your loans capitalize
Right.
onto your med school payments. You're not making enough to pay off your loan interest during residency. So these
Right.
people sacrifice a lot because this is hopefully, you know, there is a great feeling when I walk in the next morning and someone is like, "Oh my God, thank you," or someone gets teary eyed and tells, I have patients. One of my early patients that I have posted about before. I My son was maybe one when he was going through, he had a missed injury that I took care of. And he texts me or calls me on my son's birthday, February 21st, and sings happy birthday or texts me those things. And that, I don't know if there's a different job where you would have that kind of stuff. So there's a lot of positives that come along with it. And I think that hopefully we can maybe make it known that the physicians are not your enemy, really. So,
Sure. Yeah,
yeah,
I get that a lot. There's a big misconception of the sacrifices. You guys are heroes. It's a lot of sacrifice, a lot of time, years, decades, right, of commitment
yeah,
just to get to the point where you can start working
yeah.
and and then to be unappreciated and people come in, well, particularly like in the pain field, right? People come in, they're not in a good state of mind. They hurt,
Yeah,
right? That's an extra challenge
for
thrown on
sure.
top
Yeah.
of it.
And I think that's one of the things I try, that hopefully I think I have always had a, I don't know if it'd be a soft, but one of the things I think you can get into is say you've got a 1 in 20 conversion ratio. The hospital system's wondering why you're not doing more surgeries. Why are you not more productive? You're spending less time with patients. I think that's the other, benefit of running things the way that I do is because, I can really walk people through what their problem is. And one of the things I'll tell them, outright, back pain is so prevalent. How have you been sleeping? If you deprive somebody of sleep for 3 days, they will have back pain, and and that's well published. And other things like anxiety, depression, if those are not managed, it doesn't matter. I could do a perfect surgery and you won't do well. And so there are things where I'll identify in the office and hopefully get them, kind of off on the right course. Because yes, all of those things. Yeah, when you're in pain, it's not a fun thing. So that it negatively feeds on itself. All we can do is hopefully, or I guess one of the things that I've appreciated, or hopefully that I do, is that I try and get into some of those things that might be going on because it's not. I think that some physicians may be trying to bury their head in the sands, and because if you get started on a conversation about mental health issues, yeah, it can be maybe a long one, but at the same time, if you're really going to perform a case on this person, I'm very upfront about that. I say, hey, we need to either, do you have a psychologist? Are you on medication management? If not, I'll put in their, visit summary. Hey, if you have anxiety, depression, it's not well controlled, your outcomes are not nearly as good as somebody who has these things taken care of.
Right.
And so, yeah, it's one of the unique things because I think anybody who goes into, anybody who is going for surgery, very rarely that I guess that I can think of, is it not pain related. Pain brings people to the office. That's why that's why they come in.
Right.
And so I think it's those things that hopefully we can identify. And it's not that you still can't help that person, but it's trying to tell them or inform them, hey, we need you to do this so that you can have the best outcome afterwards. Because
Right.
that's what
It's
I want you to do
multifaceted.
well.
Yeah.
Yeah.
Yeah. There's so many variables and that's again advanced spine and pain. Just having a whole ecosystem that's made to help manage holistically all the different aspects of it to get the best
Absolutely.
outcome.
Mhm. Yeah, I think it's so important. Like I said, there's only 15 to 20% of people really need someone like myself or who does what I do. And there's so many other things that you can do. And I think it's so important because we are in the same clinics all the time. We have such a intertwined or close relationship because we're referring patients amongst one another, and it just, I think, hopefully streamlines care for patients. The less,
Right.
you don't have to go through a referral and then do this and then call somebody's not calling me. This is all set up to be as streamlined as possible because it's not only the right provider, right time, but also hopefully in an efficient manner, which I care about greatly. But there's so many things that get lost when you're faxing referrals to different offices and things like that. Still today, in soon to be 2026, it's amazing how many documents go missing. In my faxes for some reason, clearances, things. I'm like, what is going on? So it helps to have all of that stuff under one roof because
Yes.
it's all happening in
For
one
sure.
system.
For sure. Another good point. Yes. Yeah, you gotta, so is the plan really to build your practice and just start turning the crank and helping as many people as possible, and
absolutely. And I guess the good,
start paying those loans.
yeah, although yeah, exactly, still dipping into those, but yeah, no. As long as the good news is this model is very rare. So I'm very lucky to have been in the location at this time where somebody's willing to, take a chance on me and basically trust that I've learned well from Alexander Vaccaro and I know what I'm talking about. But this is not the way that most people have spine care set up. Like we kind of talked about, it's not uncommon for spine surgeons and pain management to work together, but the inverse is flipped. So it's seven spine surgeons to one or two pain management doctors. That's not the truth. You want that inverse, so you have 7-1 because the spine surgeons only needed 15-20% of the time. 80% of the time, the other people are going to be involved. And so that's really, what I placed my faith in is because I've seen the conversion ratio be so different between hospital employed to what I have now. It's less taxing on me to try and help people. And so I guess my faith is in the model itself. And I guess that's one of the things I do surgically is always trying to learn things. And it's not that I trial and error this in the OR, but no, I'll go to the lab and try, if something doesn't work, it doesn't work. But that's kind of the same way that I've adapted to modifying my practice and going from the hospital employed position to what I have now is, listening to people who are way smarter than I am about the way that they do things. So I think that placing my faith in this model and because I know it works and, in time, good things will come. It's been nothing but, rewarding because one, I'm actively involved. I'm listened to, yes, you do have to demonstrate that if you want to do things, it's patient care first, but two is it's financially viable and fiscally responsible. That's not, even when I would try to do those things with some of the healthcare CEOs, I was surprised with the lack of urgency that they made these changes. Will they be missing out on hundreds of thousands of dollars, if not millions of dollars, and nobody seemed to move with any urgency. That stuff drives me wild. It wasn't even affecting me at all. I'm just like, it makes my program look bad when you're not doing the things that you're supposed to be doing. So I really think that the unique thing is that this is something that not a lot of people do, especially not in the region. Rothman, and then up and down the northeast of Philadelphia and surrounding area have shown that this works incredibly well and is a great way to take care of people. I'm just very fortunate to be here at this time, in this place where other physicians who happen to have their own practices and resources are willing to listen to me and think that I know what I'm talking about, and everything has been, very rewarding, and all of it kind of feeds back on itself. I'm just constantly trying to find more ways to help people, and the other thing I think that we haven't talked about is there's a misconception about spine surgeons or surgeons in general. I think one of the jokes would be like, how do you hide a dollar bill from a neurosurgeon? It's like stapled to their kid's forehead. No. I'm the first person in my family to go to college. My parents are absolutely amazing, and I will never be able to, fill their shoes from a, time commitment I think that they put into me from my siblings for athletics or whatever. They're always there. I can't do that. But it doesn't mean because I'm a spine surgeon, I shouldn't be able to be a good father and be there.
Right.
And so that's another reason why efficiency matters so much to me. It's, it's all those things that help me be happy in general.
Right. Yeah. You can have a proper life balance where you can be the best surgeon and father and family man, son for that you can. So on that note, what are sort of the future goals then? For, moving forward on a personal side, maybe do you have plans coming up? Maybe even next year, even 2026.
So I guess one of the things I do a kind of I do a unique surgery in the lumbar spine where basically everybody is on their side. So it's called lateral single position surgery. I use robotics and navigation, things like that, where I kind of go between what most of the time spine surgeons and vascular surgeons have worked together to get down to the spine. I put a lot of time and training into learning how to do a lot of that stuff myself. And so that means that, some surgery, let's say that we're doing like a lumbosacral front back surgery. Usually, how that would start is the vascular surgeon comes in, the person's on their back, you're doing, a rather large incision through their abdomen, getting down the spine. I then come in as like basically a bone carpenter and kind of put everything in there. We then have to tear everything down, get a whole team in there. It's like a NASCAR pit crew, get this patient flipped over so you can do everything on the back. So by doing it this way, there's a need for vascular surgeons in the area. So a lot of times you're putting surgery off for patients for 6 weeks, 2 months, maybe even longer than that. But if I can do all of it safely on my own, I can get them scheduled and taken care of right away. By being in that one position the whole time, I can work in the front and in the back. So
Right.
you've cut down surgery and anesthesia time by probably half. So something might take 5 hours with what we call a turnover or flip is now
Yep.
2.5 hours. That's less time under anesthesia. That's hopefully a shorter hospital stay for the patient.
And less stressful on them during the surgery.
Absolutely, yeah, absolutely. And so, from my, I guess, what different companies, or one of the things that I hope to improve is this is a little bit, it's kind of a new thing, and a lot of the instruments, the retractors, the implants that we use are not necessarily made for this. And so that's one of the things that I'm involved in now, is hopefully trying to make all that stuff better, because it's another thing I'm very passionate about. And I think that there's nothing special about me. I'm not a savant. If you put in the time and effort to learn these things, you can do it. It will make your practice better, your patients happier, people do well. And I think that's one of the things that I do outside of the actual practice is, teaching how to do this stuff, and then also trying to be involved in implant development or retractor development, all that
Okay.
kind of stuff. I just like to try and, this is something that you alluded to. You put a lot of time into this, and I just can't imagine treating it like punching a clock. Like I can't, I think it makes it so much more interesting and fulfilling if you're engaged all the time. And
Sure.
I guess thankfully, I don't know how I became this way, but I am this way, and it helps me be involved and enthusiastic about a lot of these things that I see that can be done better for everybody.
Okay, it's awesome. Yeah, on multiple fronts, right? I mean, not just pushing forward the techniques, but also the necessity is the mother of invention, right? And you start
Yeah,
improving the toys that you use
yeah,
throughout the process.
exactly. Mhm.
Very cool. Very cool. Okay. Uh, Pete, reflecting on right back now, as a question I like to ask people as you wrap things up is, what do you wish you knew sooner about building wealth and success earlier in your career?
Well, I think we kind of talked about it a little bit. One of the things that you don't get any training on is the business of medicine in
Hmm.
residency. Thankfully, I did my fellowship. I came down here to Scottsdale to learn from. I did a combined ortho fellowship, ortho and neuro fellowship. I'm sorry, and to learn minimally invasive stuff that I didn't have an experience with in residency. Thankfully, they happen to be the group that does a lot of the North American Spine Society coding courses and book stuff. So
Huh.
I happen to get a lot of just the coding aspect of things.
Okay.
But what's been in development is definitely, when you're a hospital employee, you don't know the cost of anything.
Right.
Now that I'm in the ASC and I'm trying to make things as efficient and, cost effective as possible, it takes a lot of, you have to
The
start to
whole
learn that stuff.
learn
And
that game
so,
too. Yeah.
yeah, exactly. So I guess I think that, as I'm a huge proponent of doctors maintaining their autonomy, the just the real life experiences, you need to know that stuff.
Those
And so I
those
think that early,
constraints dictate
exactly.
practice. Yeah.
Yes, yes. It's not all, I always treated my student loans like monopoly money, because like, hey, what else am I to do? But in practice, it's not that way, and has real consequences. And if you want
Hmm.
to continue to grow your practice, you need to be cognizant of those things. So
Right.
I don't know that I have a great solution for that, because you're drinking from the fire hose constantly in training, and even in your early, years in practice. So I don't know what the right answer is as to how to teach people that sooner, but definitely I would encourage
Okay.
anybody, even in residency, just start to, because your attendings and mentors will know this stuff because they have
And
to.
it
So
and it
just
takes
try
time
and-
to push those changes through, like you said
Yeah.
earlier. I mean, this is approved, but this isn't the best procedure for you,
Yeah.
and you have to fight to get that. And then sometimes they won't, right? And then they have to pay out of pocket for the better
Yeah.
procedure, what fits them better, and that's just messed up.
Yeah.
Okay. Thank you. That was a good answer. Okay, Dr. McCunniff, if people would like to connect with you or learn more about ASAP, where can they go?
Yeah.
What should they do?
So, asappaindocs.com is our website. I give you our direct spine line, which is 480-300-6995. If you want to come in, make an appointment, like I said, we're very collaborative. We have absolutely everything in the entire spectrum of pain care under one roof. And just hopefully, like I said, I really can honestly say that I understand why there's a lot of physician burnout and things like that
Sure.
when you're going through even just the hospital employed standpoint. But I think that one of the things I care a lot about is my peers, and that, there is a cost to autonomy, but the cost of your happiness and job satisfaction is well worth it. So there are other answers than just being hospital employed. And hopefully, we can kind of maybe change some of those demographics a little bit.
For sure. For sure. The landscape is changing all the time. Excellent. Well, thank you everybody for listening and watching. Thank you very much, Dr. Peter McCunniff, for joining me today. Very much appreciate you showing your insights into the field of medicine and spinal surgery and how it's changing.
Absolutely. Well, thanks so much for having me. This is something I love talking about. So thank you.
Awesome. Thank you.
Inspired by our guests? Visit PhoenixProsperityPodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.